What is metabolic alkalosis? Why does it occur? What is the approach and how to treat it? Let's find out. Metabolic alkalosis occurs when there is increase in pH and bicarbonate with compensatory increase in PaCO2 and often accompanied by decreased chloride and potassium. Now, it occurs when there is increased bicarb generation or body's inability to lose the bicarb, or there is loss of non-volatile acids. Two stages are there, generational stage and maintenance stage. Generation is done by gastrointestinal losses, either by vomiting or nasogastric suctioning, and maintained by renal failure in the presence of volume chloride and potassium deficit, or due to potassium deficiency, which activates H plus K plus ATPase and subsequent H plus loss and alkalosis maintenance. Now, rather than mugging up the causes, let's go what is the approach. So first, rule out these things. If none of these are present, you go for urinary chloride levels. If urinary chloride levels are less than 20, that means the patient is in an ECF volume contraction phase and he or she will be saline responsive, which we will see in treatment. So ECF volume contraction is either due to gastrointestinal loss, that is vomiting or nasogastric suctioning, or there is diuretic use or post hypercapnia. If the contraction is not present, then it might be due to exogenous soda bicarb or multiple transfusions. If the urinary chloride is more than 20, so check BP. If hypertension is not there, that means there is renal cause, Bartter syndrome, Gitelman syndrome, diuretic use, magnesium or potassium deficiency, recovery from lactic acidosis, or there is addition of non-reabsorbable anions in the form of penicillins or carpenicillins. If hypertension is present, so we will check for RAS, renal angiotensin aldosterone system. First, check renin levels. If renin is increased, simply 4 causes: renal secreting tumor, renal artery stenosis, accelerated hypertension, or hyperestrogenemia. If hypertension is present but renin is decreased, so you go for aldosterone levels. If aldosterone is increased, there is primary hyperaldosteronism, that is adrenal hyperplasia, adenoma, or carcinoma. But if aldosterone is decreased, then we have 4 to 5 causes: Cushing syndrome, corticosteroid use, Liddle syndrome, or there is 17-alpha hydroxylase synthase deficiency, or there is licorice, that is molality overconsumption. Coming to the treatment, if patient is volume unresponsive, that is in volume expansion phase, so you have to correct the underlying disorders and then go for treatment. But if patient is in volume responsive phase, use fluids, correct the volume potassium and chloride deficit. Fluid of choice is usually NS with KCl or isolite G. Now, if it is diuretic induced, reduce the dose of diuretics, give potassium chloride and carbonic anhydrase inhibitors like acetazolamide, which help in renal loss of bicarb. Now, what is not to be used? Ringer's lactate, acetate citrate, or soda bicarb. Rarely it is postulated that 0.1 normal solution of HCl can be used, but given very slowly and via large veins like femoral or subclavian vein, because it is very corrosive and it might lead to thrombophlebitis. Last option in severe metabolic alkalosis is dialysis. Thank you.